Welcome to today's edition of The World Today on the next pandemic, because that's what we really want to be thinking about right now. We're delighted to be partnering with the Penn Center for Research on Coronavirus and Other Emerging Pathogens, and to welcome our speakers to the virtual stage today. Frederick Bushman is the W.M. Measy Professor and Chair of Microbiology at the Perelman School of Medicine at the University of Pennsylvania. He received a PhD from Harvard University, and his research centers on host microbe interactions with specific projects focused on coronavirus and HIV. He was also the principal investigator on the Human Microbiome Project and a founding principal investigator at the Penn Center for Research on Coronavirus and Other Emerging Pathogens. Susan Weiss, who we're happy to welcome back to Perry Worldhouse, is professor and vice chair, Department of Microbiology, and co-director of the Penn Center for Research on Coronaviruses and Other Emerging Pathogens at the Perelman Center at the Perelman School of Medicine. She also received a PhD from Harvard, a lot of slackers here. And her long-term research interest is in the pathogenesis of human coronaviruses, with a current focus on virus interaction with the host and immune response. They will be in discussion with Harvey Rubin, who is professor of medicine with a secondary appointment in computer science at the University of Pennsylvania. He was a member of the U.S. National Science Advisory Board for Biosecurity in the Department of Defense National Academy of Sciences, a biological cooperative threat reduction program. He's also the person at Penn that I would probably email if I had a health issue. He's been a great friend at Perry Worldhouse for a number of years, and we're honored to have him here with us today. And so with that, thank you to all of our panelists for taking the time to be here. And let me turn it over to Harvey to kick us off.
Thank you, Michael, and thank you, Susan and Rick, for joining this conversation. I think it's really important that you gave this a title of Future Pandemics. As a society, as a culture, we're so focused on what's consuming our lives now, but it's really important not to miss the idea that this is not the last pandemic. We really have to think, what have we learned from this, and how do we prepare for future pandemics? We're listening to experts, and that's the first start. But we need more than that. And that's why I am absolutely thrilled that the Perry Worldhouse has taken this on, because it's not just an issue for experts. It's not just an issue for physicians and for virologists and immunologists. The way we need to respond to this pandemic and any future pandemics is a whole of society approach. It's going to take politicians. It's going to take religious leaders. It's going to take deep thinkers in philosophy and history. So having the World Center really consider this is maybe the most important thing we do. Scientists talk to each other all the time, and it's our job to get out there and start talking and educating and learning from the community. And so we are absolutely just the audience. I see Susan and Rick all the time. To be able to hear these two experts is really a once in a lifetime. So I'm going to shut up now, and I'm going to turn it over to Susan. Even though I thought we would go alphabetically, I'm going to take the privilege of being the moderator to turn it over to Susan, who is sometimes known as, and I know she hates this, the mother of coronavirus, as it said in the Penn Gazette. And wrote a really interesting little review, a big review called My 40 Years with Coronavirus in JX Med. So Susan, you have 5 minutes, take it away, please.
Okay, so as Harvey said, I've been working with these viruses for a very long time, really my whole academic career. So I want to just review a little bit about coronavirus research history and how that informs us about the current pandemic and also how to think about future pandemics. So going back to the 60s, we knew about human coronaviruses as common cold viruses, but we also knew about a lot of other coronaviruses that infect just about every species of animal, from cows, pigs, dogs, cats, everything, just about every animal. And there was a lot of important vaccine research done for these pathogens. And so from then until, say, about the year 2000, there was really a lot learned about coronaviruses, like the spike protein that we all hear about, that's the target for vaccines, was identified back in the late 70s. And we knew that it was cleaved by a furin enzyme, just the stuff that's really relevant to making vaccines today. We also knew a lot about how these viruses replicated. We identified 16 proteins that are conserved among all coronaviruses. So we really knew a lot. The viruses had been sequenced and cloned, so that in 2002, when the first SARS emerged in southern China, it was identified very quickly as a coronavirus. And I have to say that the small group of researchers that worked on these viruses were absolutely shocked, because until that day, we had never heard of any kind of really pathogenic human viruses. We were really calling each other up in shock. But anyway, because of all that we knew, it was identified very quickly. And then we learned subsequently that coronaviruses have a reservoir in bats, and that this SARS-1 actually was transmitted from a bat through a civet to humans. And people started to make vaccines and to look for antivirals at that time, but then that epidemic was gone in 8 months, so people kind of forgot about that. And then in 2012, Middle East respiratory syndrome virus, causing a very similar disease, emerged in the Middle East. This time it came from a bat and has a major reservoir in camels, where it still lives. Many camels are infected with this virus. And again, there were some attempts to make vaccines and antivirals, but that virus is still causing infections in the Middle East only. And we kind of forgot about it. So that in 2019, the end of 2019, when the second SARS emerged in Wuhan, China, a different part of China, we're pretty amazed, although each time we're a little bit less amazed and a little bit more horrified that we hadn't done more to prepare for it. So I think that, just to emphasize that we had all these opportunities to have really developed vaccines and antivirals. More so, antivirals are really important for these viruses because, as I mentioned, they all have very, very similar genetic material and they make very similar proteins. So an antiviral directed against one of these viruses would very likely work against all of them. For example, we have remdesivir that everyone's heard about, that is directed against the enzyme that replicates the RNA, the genomes of these viruses, and that really would be effective against all of these viruses. So I think people now are seriously looking at antiviral therapies, and I think that has to, even though we have a vaccine, I think it's super important that we keep developing antivirals, because if another coronavirus emerges from animals again, it likely will not be, we will not likely not be protected by the current vaccines. We will need a whole new round of vaccines, most likely. And we will need these antiviral therapies as a quick response to whatever new virus should emerge. And as Harvey mentioned, I think we will have emergence. We know of these 3 emergence of coronaviruses, not to say about other types of viruses. And we don't know if there were other emergences from bats to humans that we just didn't really recognize because we didn't see a lot of loss of human life or a lot of sickness. So we really don't know how often this occurs. So in addition to developing drugs, I think that we need to keep developing vaccine platforms so we can easily switch from one mRNA vaccine to another one, or from an adenovirus delivered vaccine as well. And theoretically, that's not very difficult, but it will take time. And in that time, we would hopefully have drug therapies. And the other thing there are 2 more things that I think are really important to get ready or to prepare for possible vaccines. And one of them is to really keep studying these viruses and really understand every detail of how they interact with their hosts. We still have no clue of why SARS-2 can spread asymptomatically or pre-symptomatically, which seems to be the reason why it's spread as widely as it has, as opposed to the first SARS-1 or MERS. And the other thing that's really important that is going on is to keep surveying bats and other animals to look for viruses that have the potential to spread from the bat into another species or directly into a human. And that will inform us about how to regulate animals in these wet markets that may be transmitting these viruses. So it's really important to understand the chain of transmission from the bat, probably through another species that may be around humans, into humans. So those are my 3 recipes for going forward, is understanding more and keep developing drugs and vaccine therapies. And I will stop there. You're muted, Harvey.
Thank you. I'm going to take the privilege of asking a couple of questions before we turn it over to Rick.
Okay.
So SARS-1 went away in 8 months, as you said.
Yes.
MERS is now kind of restricted to a geographically quite distant place. If we had to go back and learn a lesson, a policy lesson, given who the Perry World House really caters to, if we had to learn a policy lesson, and I know you've been involved in NIH review committees, where do you think the resources can come to do all the things that you so correctly point out we need to do to prepare for the next one? Is it a government? Is it a world governance situation? How do we actually gather the resources?
I think it's a mixture. I mean, people at my level doing this basic science are mostly supported by NIH. The drug companies are really have come forward to work on the vaccines. I know drug companies are also doing a lot of antiviral research. So I think a lot of the money is going to come from the drug companies and the government, right? The warp speed has been supported by the government. So I think, and probably it would be a really good idea to have cooperation among countries. I mean, Rick can talk more about this, but the sequencing efforts are being done all over the world, and hopefully they will be compiled in one central place. But it's a very big question. Obviously, I know that this group is looking at the origin of SARS. That's a combination of WHO and the Chinese government themselves. So I think this is going to require a lot of cooperation among a lot of different bodies.
That's great. You're really laying out a very difficult problem, and the segue is perfect. So I'm going to turn it over to Rick, who has an enormous amount of experience in not only coronavirus, but the other pandemic that the world confronts, which is of course HIV. So Rick, will you take it away for about 5 minutes, and then we'll pose some difficult questions for you as well.
Okay, thank you, Harvey, and thanks to Perry Worldhouse for hosting this event. So I'll touch briefly on what's going to be the next big one and what should we do to get ready. So any good microbiologist is going to have their own favorite guesses for what's going to be the next giant pandemic that afflicts us. What are the characteristics that you would expect? Well, the agent will have to have efficient human-to-human spread, animal reservoir. It looks like for the coronaviruses, there probably was a single jump, which leaves them vulnerable. If we can eradicate them, as with SARS-1, they're gone. Influenza, unfortunately, has robust animal reservoirs and commonly circulates between humans and animals. So having a robust animal reservoir is likely to be a contributing factor to the next big one. Pathogenesis. How pathogenic would the next big one be? With SARS-CoV-2, as Susan mentioned, we see that there's asymptomatic spread, and that's probably a big feature of why it spreads so efficiently. It's been pointed out by a number of authors that how pathogenic an agent can be is linked to their mode of spread. So that a sexually transmitted disease, for example, needs to preserve their host relatively healthy in order that they can transmit. Otherwise, the disease will die out. So a disease that's spread by biting insects, the host could be flat on their back. Biting insect can still bite them, fly away, and bite somebody else. So to really spread efficiently between humans, probably respiratory viruses like influenza or coronaviruses, although it could be biting insects. HIV is sexually transmitted, so there's all of those. Asymptomatic spread, though, is a feature that seems to be consistent with efficient spread between humans, provided it's not from biting insects. So what's going to be the next big one? Influenza or coronaviruses. Others could include monkeypox. There are flaviviruses like Zika, which you've probably heard about. A host of others, Ebola, Marburg. We can debate the features of each, but those are all ones people are worried about. What should we do to get ready? Stockpile PPE more than we did. I totally agree with Susan. Basic research leading to the development of generalized inhibitors that can act against like all the coronaviruses, not just one of them, all the flu viruses, not just one of them. The mRNA vaccines look to be a game changer because the technology is pretty easy. Just get a different mRNA, make that up. It's a lot of the pipeline's the same, and it's pretty easy to switch to the next one and the one after that. So building out infrastructure for making the next mRNA vaccine and the next one, so that should a new epidemic emerge, we can quickly make up vaccines that way. That really looks like a game changer. and just sensible management. Many of you probably saw the New York Times article that the US has had a sort of pandemic preparedness unit, and they spent most of their money stockpiling an anthrax vaccine. Anthrax can be treated, it's not clear how important that is. Anthrax can be treated with antibiotics. Plus, the vaccine went bad, so they had to buy it again every few years, and like much of their budget went to that purpose. So, you know, everybody likes having an anthrax vaccine around, but still, it seems like there could have been better management, and of course, increased resources would be valuable given everything we've seen so far with SARS-CoV-2. So I'll stop there. Happy to take any questions or elaborate on anything.
Great, thank you, Rick. There are a bunch of questions coming in from the audience, but I'm allowed to ask one question before I turn it over to the audience. Rick, you laid out all of the issues that you would be concerned about. When I served on the first couple of iterations of the NSABB, National Science Advisory Board for Biosecurity, we were very worried about experiments of dual use of concern. And the issue always came up is, what experiments would you not want to do? You laid out a whole series of experiments, the answer to which might be used for nefarious purposes as well. Are there any experiments that you would not want to see done in terms of what if there is a lab accident, or what if this information got into the wrong hands?
Well, I think the regulatory framework is pretty reasonable that we've heard about so far. For example, there's absolutely no evidence that SARS-CoV-2 was made in a laboratory. That almost certainly was a product of an animal jumping to virus in an animal jumping to humans and spreading afterwards. Introducing genes into a pathogenic virus where you have a reasonable suspicion it would make it still more pathogenic, I think would be bad. And then trying it out on humans would be, of course, totally unethical and bad. I think anything about, well, maybe I shouldn't even say this, but the one that would worry me the most would be trying to expand stocks on humans and see which ones grow the best, do a sort of Darwinian competition. So, you know, people have debated, should we have remade the 1918 flu virus? That was reconstructed in laboratories based on molecular information.
Right.
And the argument is that could be dangerous. That might be bad. It could be a weapon. Going the other way, it could help us prepare, make vaccines, make antivirals. There, I think people were pretty careful, and ultimately it was resynthesized. And I think it's been valuable to be able to prepare for that. So I would take it on a case-by-case basis, but I wouldn't engineer viruses to make them more aggressive in humans. That would be bad. Right.
Actually, that flu experiment, that was the first case we heard in NSABB, and you're exactly right. So gain of function experiments you would be nervous about. We have a lot of questions, and I think the very first question is, and I'm going to wait to the end for you guys to answer this, but the very first question is, do we think that the current pandemic has really prepared scientists and the public for future pandemics? So that is the ultimate question. So we're going to come back to that at the end, but I think that is the question we all have to answer. One of our colleagues from Penn just wants to focus quickly on this event. Susan, maybe you can handle this. What do we know about the timeline in terms of the spreading from the reservoir to human transmission? Do we have that timeline nailed down yet?
No, we don't have that timeline nailed down yet. And just for historical purposes, when SARS won, it took quite a while to figure out where it came from, and we finally did. So that's certainly being explored by people like Peter Daszak. And right now, just recently, there was a commission in China, a group of, I think, WHO and Chinese scientists really looking at that question. And there's going to be a report coming out really soon. So I think that most people that in the know would say that it clearly came from a bat. There are similar viruses in bats, and probably was transmitted through an intermediate species. And it probably did not originate in the wet market. That was the original idea. That might have been a super spreader event or something like that. But I think there's good evidence that it was in China earlier in December.
Right.
But we don't know where it came from.
Right. Do you have a sense of the timeline? When do you think we might know that?
I think this report will give us some information.
Okay.
It's going to be released really soon. I don't think they have the answer, but they have some thoughts on it and some information. And it's, as Rick said, it didn't come out of a lab. It came out of an animal into people. That's almost for certain.
Great, great. Yeah, thanks for that. You're hearing it from people right at the front line. There is a question that comes in from the audience about current risk assessment. And I think this is relevant because we're talking about future pandemics. And the specific question is the risk assessment of the AstraZeneca vaccine in terms of intracerebral bleeds and blood clots. And the question really is, how does one assess risks and benefits of any particular product? If you're looking at a 40,000, say, patient phase 3 trial, and you see maybe one side effect, one adverse event, what about when you start immunizing 40 million people? Are there ways that we could think about going forward for a more robust, sometimes people call it pharmacovigilance, or a more robust risk assessment? Is there anything new on that in that world? Rick?
Well, it's a hard problem because there's going to be a rate of bad things happening to people without them getting the vaccine. So how do you know exactly what that rate is? And then you see some rate with the vaccine. Is it the same? Is it different? What do you really know? It takes a bunch of mathy stuff to try to really assess your uncertainty in each setting like that. It's easier when you have a placebo-controlled trial, which is part of the reason it takes so long to develop a drug or vaccine, is that you get a large number of people and test them with the vaccine, a large number test them with a pretend vaccine, and compare what happens to the people. Do they have adverse events or not? And at what rate? And mathematically, given a background where bad things happen to people from time to time without any intervention, what do you really know? And so what you're describing, Harvey, is the very difficult situation where you have very rare events, vaccine rollout, and then you ask, are we seeing these very rare events more often than you expect by chance? Another way of looking at it is, well, how bad is the disease? How sure are you you're preventing the disease? And how bad is that? And then you say, well, even if this is a side effect, is it as bad as the disease? Is it worse? Is it better? I think in these cases you are describing, the disease is much worse than and more frequently bad than the adverse events. But still, of course, you have to pay close attention and try to make it as safe as possible. So it's a difficult balance. Some of it turning on what do you really know about what's going on with the background population without any treatment.
Well, let me follow up on that because it's actually part of the same question. Is that true? We need the data. The big question that comes, and this is true for any future pandemic, and this one is who do you listen to? Who are the communicators? Do we listen to Professor Bushman and Professor Weiss and Dr. Rubin or Dr. Horowitz? And of course, the president was asked that question the other day, and he said, "Should the former President Trump be out there?" So it really becomes an issue of who are the appropriate communicators. And let me just put a point on it. Suppose some politician got up and said, even a trusted politician got up and said, "Don't worry about it. This is a small number on top of a big number. It's just background." Is that the trusted person? Is it the corporate? Is it the president or the CEO of AstraZeneca? Who? And I'll open this up to both of you because as a member of the public, we want to know who are we listening to. So Susan, let me hit you with that.
I think that through most of this, we've been listening to Tony Fauci. I think he's no, I do. I think he's been really the voice of reason and rational thought about the whole thing, and knowledge, of course.
Yeah.
Yeah, subject area experts obviously are the people who should be generating policy. And then from there, who's articulating, I think, is whoever will get through to the people you need to get through to. It's great if there's a responsible administration that's having a constructive voice. It's great if they're like celebrities, sports stars, whatever, who are also constructive voices, giving the right message. And then another piece of the message, I think this has come through from Tony, often not from other sources, is to be clear about uncertainty. We don't know exactly what the situation is here. We think the best course is this. That's how we're going to move forward. We're going to gather information in this kind of way. We may adjust downstream on the basis of this, on the basis of that. Just reassuring the public that there's sensible decision-making, even though we have incomplete information.
Yeah, actually, it's interesting you said that. I actually saw an interview with Tony Fauci this morning on TV, and they asked him, what have you learned over the past year? And he said he learned basically to be humble and to recognize that science changes, and we have to be able to honestly tell the public what we believe today, but that it might change tomorrow. And I think the public thinks of science and medicine as written in stone. This is the way it is. But we all know that that's not the way it is exactly. And I think the audience should recognize that exactly that you say, advice can change. In terms of going forward, the question that I get a lot, and is a question right here, are we worried about the variants? Is that the next pandemic? Maybe we could take that, Susan.
I have some thoughts about that. I don't think it's the next pandemic. So most of the variants, as Harvey and I have discussed, are not result of immune evasion. They're viruses so viruses change all the time, particularly RNA viruses. And the more time they have to replicate, the more they're going to change. And they're going to change in a way that allows them to replicate better. As Rick said, they want to spread. They don't particularly want to kill people. So these variants are most of them are just viruses or variants that evolved to enhance the spread to people. They're not necessarily going to compromise the efficacy of the vaccine, although we think that maybe a few of these mutations may do so. But I don't think it's going to turn into another epidemic at all.
Rick, you worry about surveillance. Can you comment about the level of surveillance in this country and global surveillance? Is that something we should be really concerned about?
Yeah, I think it's useful to watch the virus evolve using the viral whole genome sequencing. Ask how it's changing. Does it matter? Do we need to change the vaccine in response? I'm concerned. I think it's a race between the virus evolving to grow on vaccinated people versus us suppressing the virus with vaccines and masks and social distancing and all the tools we've been using. So, we're in America's costliest war with 500,000 dead, and I think we're hoping we're in the final battle, but I could still see it going either way. So, to all of you who are listening, keep up wearing masks, engage in social distancing, be careful. We're sequencing viruses from the Philadelphia area. We have 16 detections of the UK strain, so it's definitely spreading in our area. There's good evidence it's more transmissible, weak evidence it might be more pathogenic. And then there are other variants coming on, the South African strain, the Brazilian strain, that have some substitutions that clearly are blocking antibody responses in reconstructed experiments. And so one is the E484K substitution. I heard it called the EEK substitution recently in a call. And we've seen that here in Philadelphia, not the Brazilian strain, not the South African strain, but that variant, that substitution appearing in a local strain. It's called R1 is the name of the variant. And it was in a vaccine breakthrough. So that to me is very worrisome. We're in a pitched battle. And at this point, I could see it going either way, with the variants evolving to grow on vaccinated people and overwhelming the system, or vaccines and social distancing and masks and everything suppressing the virus so it's gone. So I would urge everyone to keep up precautions. I think it's on the edge.
Can I make just one more comment?
Sure.
I agree with Rick. I guess I'm a little bit less worried than he is, but I think that if we stop the virus from replicating, that is by vaccinating as many people as possible, that's going to slow down the rate of variant. And it's not like the UK variant came here. It's like this is a natural selection for a better growing virus, so it can happen anywhere. And I think at some point, I could be wrong about this, but I think at some point it'll reach a kind of equilibrium where it's optimized for spread in humans. And maybe that's the point to think about making a second vaccine or a booster vaccine or something like that. But yeah, I mean, these are just natural variants and natural selection in action. And the reason we probably didn't see this with SARS or MERS was because they weren't around long enough. They didn't replicate enough times.
Yeah, yeah, fascinating. And that really does raise the point that even though you're vaccinated, you should still wear your mask.
Yes.
It's really, really important. Um, and so I think we could talk all day about these variants, and I think it's a fascinating area. So here's another question that has huge policy implications, and that is the role of the zoonotic spread of infections. Not just this, but all the other zoonotic infections. If you look at the rate of increase of human disease and the number of spread between animals and humans, it's going up. And that's because of urbanization and globalization, you name it. Are there any policy positions that we could take that would mitigate the spread of zoonotic and animal-human transmission? How do we do that without wrecking the biosphere, as it were?
I think one is influenza, where we know it replicates in pigs and water birds, and we can identify those hosts quite readily. So there can be surveillance, and at the first sign of an outbreak in pigs or water birds or what have you, that can be contained really aggressively. And we see that to some degree globally. So there's a case where we know what to keep an eye on. They're under our control, and we can, if there seems to be an incipient outbreak, we can squelch it on the spot. Others are much harder. If they're, if it's bats, we can't go around killing all the bats in the world. Or civets or stuff like that. So there it's much harder. All we can do is sort of keep careful surveillance of people getting sick in remote regions and stuff like that. Perhaps viral genome sequencing to try to see if it's something new,
Right.
follow up as appropriate.
But also maybe keeping the live animals out of wet markets seems to, at least for the corona, seems to be the way that it's happened.
I remember in the early days of this, people asked me, should we shut down wet markets? And my answer was yes. And then I got clobbered because people said I was insensitive to the cultural significance of wet markets in various communities. And that was a very valid criticism. I think these are issues that go well beyond the science and the medicine. It involves cultural identity and living. So we have to consider this. But again, it's a great thing for this community in Perry Worldhouse to think about. What does it mean to intervene and mitigate when you have enormous cultural consequences? And here's another question that's really actually quite dear to my heart. There's now a reemergence of Ebola, especially in Guinea-Conakry in West Africa. Do you see what is the relevance of a global pandemic in the context of other smaller but still very significant outbreaks? And how has the pandemic impacted vaccination for other things? If you look at the data during the Ebola crisis in West Africa, the rate of childhood vaccinations went way down because nobody wanted to bring their kid to the medical center. And if you look at vaccination rates among kids, even in this country, and certainly in low and middle income countries during COVID-19, the rates are going way down. So we predict in the next 6-12 months, there's going to be a resurgence of childhood illnesses. So the question is, how do we think about this pandemic in the context of the bigger picture of infectious diseases? And are there things we can learn going forward?
Well, a couple of optimistic things. One would be the mRNA vaccines, as we mentioned, can come online really quick and be used to treat an outbreak. So maybe mRNA could be deployed for Ebola. I think that would be a fantastic use of the technology and really sort of uplifting to see something good come of all the bad things that have come of SARS-CoV-2. And then going the up, I think it's terrible that vaccination rates are going down. It's essential that people get their regular vaccinations. But today we see people, trying to get in line to get the SARS-CoV-2 vaccination. Maybe they'll create a different sort of emotional feel around the whole thing, where it's something really great that you're, really hungry to get when it's your turn. And I'm hoping that there might be a change in perception towards vaccination due to the epidemic.
Susan, any thoughts?
I was just going to say, vaccines aren't really the only thing that have suffered, right? From what I understand, people have stopped doing screening like mammograms, and all that kind of stuff's been put off. So it's got a much bigger impact even than than
Yeah.
delayed vaccination.
You're absolutely right. I mean, this has an enormous consequence. I'm going to skip one question to get this other question because it does speak to other global events, and this is a question that I know I get asked a lot, and maybe we're in the wrong audience, but one of the questions is, how does global warming affect the pandemics? It may not, I don't want to be outside of our realm of expertise, but a lot of people think about that, and now you even hear, well, it's getting to be warmer weather, it's going to, blah blah blah. So tell me about your thoughts about global warming. Add one disaster on top of another. What do you think?
Well, you're thinking about global warming somehow affecting the contact between bats and humans, and that's, I don't know if there's a direct connection there.
Yeah.
If there is,
Well,
that could be, yeah.
Yeah, I think it's really this whole notion of climate. I mean, if I can interpret the question, it's really, does climate change the either the impact or the probability of future pandemics?
There is one concrete way that it's having an effect, which is changing the ranges of mosquitoes. Many diseases are transmitted by biting insects, and people are carefully measuring the expansion of mosquito ranges, like, moving north in the United States in multiple regions, and spreading arboviruses, viruses that are carried around by mosquitoes and other diseases along with them. So that's a very concrete thing that very measurable.
Yeah, I agree. If you look at, and the data is pretty clear, if you look at the level of malaria, for example, it's getting at higher and higher altitudes, and because mosquitoes are now able to survive under higher, at higher altitudes. So I without going through all the data, I am absolutely certain that climate change is going to change future pandemics. And that's because of the way water is handled, temperature changes. If there's a waterborne illness that becomes a pandemic, it's going to, obviously that's going to change as well. So I think that was a really great question. Then there are some very general questions that I think we all struggle with, and that is, what things do government policies need to be put in place to prepare? If you go back and look at the history of this particular pandemic, it's not as if nobody told us that this was coming. It didn't all of a sudden appear on our shores. There are a lot of articles in the Atlantic and the Wall Street Journal, everywhere there's going back and showing people were warning about this for a long time. Why were there not policies put in place? Is it because it was too expensive? Is it because that nobody really believed it? Were there pre-existing biases? What do you think? Rick, what do you think? Susan, sure, go ahead.
And I was just gonna say, it's probably a combination of things. Maybe not quite believing it's gonna happen again. It's expensive, both of those things. We should have had PPE, obviously. There was a real shortage at the beginning. When we heard about it, we immediately bought PPE for our lab because we were gonna be working on it. And the whole testing thing was kind of mishandled. I mean, it's such a simple test, a PCR test for a coronavirus, yet it became this huge problem where people had to send it to CDC. And I mean, that could have been set up so much more efficiently and quickly. So those are some of the things I think that really, and also our government at the time was not exactly well organized for it, put it that way.
Yeah, Rick?
Yeah, I think it's hard for leadership under any circumstances to set aside resources for something that might possibly happen a long time in the future when there's so many immediate demands. And so that's kind of this national stockpile thing. There was a national stockpile, but somehow it devolved into just buying the anthrax vaccine over and over again. Going forward, we can build out manufacturing plants for mRNA vaccines that are flexible and can be used for lots of different things. I think we can do it much better. Stockpiling PPE, as Susan mentioned at the beginning, doing antiviral research, studying, the functions that are present in all coronaviruses, and all retroviruses, and all alpha viruses, and then trying to find small molecule inhibitors that work against, a large fraction of all of them. So it's likely to work on the next one when it comes along. That seems like a pretty achievable goal, and people are already talking about that. So I think all of these things make sense. I think history will not be gentle with the past administration. Part of the testing problem, I think, was they didn't want to know the answer, or I'm guessing anyway. So sound leadership and well-informed leadership, I think, are key.
I think that's great observations. Going forward, then we're hearing a lot about who was tested, and you refer to that. People don't get tested, and also in terms of developing antivirals and vaccines, certain populations are actually excluded from phase 1, phase 2, and even phase 3 trials. So pregnant women and pregnant people and immunocompromised folks, children under the age of 16. How do you see going forward so that we're not behind the 8 ball? And I get a lot of questions. I want to become pregnant. Should I take a vaccine? How do you see going forward that should we be changing the criteria to be in either a clinical trial or in a testing program? How do we make this so that it's a smoother transition for mass vaccination?
It's a tough.
That's a hard one.
Yeah, it's the Perry World House. What do you expect, right?
Yeah, I mean, of course, you want to protect pregnant women. On the other hand, everyone remembers thalidomide and horrible meltdowns where there have been particular vulnerabilities and disaster that ensued. One thing would be sort of an orderly, slow rollout of the mRNA vaccines into other populations, and then comparison. Is the adverse events, are the responses to mRNA vaccines about the same from vaccine to vaccine, or does it matter what protein they're encoding? Is it really different? Not really different? Can we get to some kind of generalized solution and then test it carefully based on mRNA vaccines? But I don't know if an mRNA vaccine against Ebola would have the same side effects, same adverse effects in vulnerable populations as mRNA vaccine against COVID or something like that. So a lot of things to try to figure out, but I mean, you can totally see both sides. You want to protect people, but there's very serious vulnerabilities also that you have to respect.
As far as testing, I don't see any, if we had been more prepared for more testing, we could have tested anybody. It became ridiculous where you couldn't get a test unless you had really severe symptoms.
So let me really push on this, because I know we're going to get asked this. We think about democratization of a lot of things. Who should be making those decisions? Suppose I come to you and I say, I really insist on having pregnant people in my next clinical trial, or whatever. And who should be making those decisions? Should it be, I'm not even going to suggest, knowing that the downside as well as the upside? How do we even begin to answer that question? I would turn this over to the Perry World House audience as well. We're scientists. I think this is a societal question where it takes informed decisions. And I don't know I'll answer this question myself since I posed it. I don't know that only scientists should be responsible for this decision. And this goes back to, what is the role of the scientist in society and culture? Should scientists be the ones responsible for targeting atomic weapons, or, who should be making this decision? So I'm going to turn it back to the Perry World House audience and keep my two friends from saying things they would be. Let me just ask, I know we're running out of time, but there are a lot of questions of, and this is not for the future, but are we going to need boosters? Yes or no? What do you think for COVID-19?
I could see it going either way. I think one extreme scenario would be the SARS-1 scenario, where we drive the virus to extinction. It's not coming from an animal reservoir over and over again. We break transmission in humans, and it's just gone. That would be so great. On the other hand, it could take an influenza-like route, where the virus is circulating in the world. It's changing. Every now and again, we need a booster with a new for the latest variant that's growing through people, the way we've seen with flu. It's not the end of the world, but it's not the greatest, because there's a lot of morbidity and mortality with flu every year, of course. But it's manageable. It'll be easier with the mRNA vaccines, I think. So I think it's on the edge. I mean, that's why it's so important now as we get vaccinated. Keep wearing masks, keep up precautions. The enemy's starting to crack in this giant battle. So keep up the pressure, disperse them, reduce their numbers. Don't go have lunch and go golfing or something like that. Keep up the pressure.
Yeah, I don't think it's going to be quite like flu, because flu has a very special way of changing more radically than this virus has. And as I said before, I think it will evolve to a certain point when it's all optimized. And maybe I'm being optimistic. I don't think it's going to keep it, unless it keeps infecting vaccinated people and does immune escape kind of mutations, which are more dangerous, in which case we would need a booster or another vaccine. But I don't really see it as a chronic thing. As Rick said, as long as we can beat it out and make it stop replicating a lot, I think we won't have to keep vaccinating every year like flu. That's my prediction.
Well, that's good. See, even the scientists have approached this. Rick, did you want to respond to that?
I just said hope so.
Hope
We don't know. We don't. I agree. We don't really know. But if I had a bet on it, I would bet on no. But
right.
Maybe one more booster.
Michael, can you tell me we're at 10 minutes to the hour. Michael, maybe if you unmute, what should we do for the last 10 minutes? Give us some advice.
I would take some questions from the audience.
Okay, we have some more questions coming in. Let me see if I can. Let's see. I think we've covered a lot of these. There's a question about rebuilding the public health system. We failed to test and trace. South Korea has used effectively pandemic mitigation. Is there anything we can do in terms of rebuilding the capacity in this United States? What do you think of that?
I think there's plenty we can do, all under the general heading of preparedness, building out infrastructure for mRNA vaccines, stockpiling PPE, making generalized inhibitors, getting people in place who are ready to go for the next one. Maybe they have to be public health professionals or doing something else most of the time, but have people trained up so that if Ebola hits the United States 2 years from now, we have efficient contact tracing, ring vaccination, which means vaccinate everybody who ever went anywhere near the case, to prevent further spread, and squelch it, when it hits our shores. That's all very possible, and a little preparation will go a long way.
One of the things, not exactly the same question, that I keep thinking about is that one of the differences between SARS-1 and SARS-2 also was the contact between China and other parts of the world. When I went to China in 2003, right after the SARS, the first SARS, it was a really foreign place. It was very different. And there weren't a ton of flights back and forth the way there are now. So I think that this vaccine spread really was enhanced by just by the world travel. I wonder if SARS-1 had come out now or in 2019, if it would have spread over here, which it really never did. Yeah. It did get to Toronto, but it never really got to the US.
Yeah, good point.
Another thing is just the global population density. As it goes up, viruses or other infectious diseases are more poised to spread through the populations. As populations larger, often, many of them have impaired health or, food insecurity. Is that a right place for next disease to spread? So
yeah,
it's not fashionable to talk about overpopulation today, but thinking constructively about human population growth, dealing with food insecurity. Not as I think Fauci said, no one's safe till everyone's safe. SARS-CoV-2 and the next one as well.
I also wonder, just sort of the converse, that were there remote places in China or other places in Asia that had outbreaks of SARS-like viruses where some number of people died and nobody really noticed it. It's certainly plausible.
Right.
There was this one case they talk about, I think in 2015, a bunch of people died of it turns out it wasn't, I don't think it was SARS-2, but something close to it. And it was just sort of not reported.
Right. Well, there's a couple of questions about this notion of herd immunity, and can we ever get to herd immunity given the effectiveness of certain vaccines? Let me just set the stage. Herd immunity is a number, we heard it. Well, first you need 50% people vaccinated, then it ramped up to 70, 80%. The general equation for a well-mixed population is you get herd immunity when 1 minus 1 over R naught is vaccinated. And so it depends on how transmissible the virus is. That's in a well-mixed population. So if R naught is, say, only 2, that is, I give it the disease to only 2 people, that's 1 minus a half, or 50%. But if you have variants that spread more rapidly and I give it to 3 or 4 people, then it's 1 minus 1 over 4, or now you're up to 75%. So as the R naught, the number of people you infect changes, that changes the target of herd immunity. And that's why that number changes. So again, that's for a well-mixed population. In what we've been seeing emerge over the past couple of months, maybe with these variants, as you said, Rick, maybe more transmissible. How do you see the ever receding issue of herd immunity, from 50 to 60 to 70%? How are you thinking about that now?
I don't know. I mean, the population's clearly not well mixed. There are outbreaks in among vulnerable people in prisons, places like that. In our medical school, there seems to be pretty much zero transmission, at least within the school, for people getting infected at work. So very wide ranges of rates of transmission. So maybe we've already accomplished a lot by vaccinating the most vulnerable, elderly, so on. As we get to the people where the rates of spread are the highest, maybe we don't need to go that high. Another optimistic possibility, maybe a lot of people have been exposed, mounted an antibody response, and never even knew it. And so that the immunity is a lot higher. Going the other way, maybe those things are all minor. It is the well-mixed thing. It's going to be really hard to get to everyone in the population because of vaccine hesitancy and all the issues, some of the issues we've discussed before. So maybe it'll be really hard too. I once again, I'm being very wishy-washy. I could see it going either way.
Yeah. Lots of questions. Yes, there's a question. Yes, wear a mask even though you were vaccinated. You can get together in small groups if you know you're vaccinated and your next door neighbor is vaccinated and you're very low risk population. You can join each other in your house unmasked. That's the CDC recommendation. But small private gatherings is not big public gatherings. There's a difference between personal behavior and public behavior. You gotta wear your masks out in public. There's been a lot of questions about communication, which is really interesting because I think we've not done a particularly good job, we meaning as a culture, as scientists. I think you're right, there's some people who are on TV a lot and they do a great job. It is our responsibility to communicate. I talk to my patients about this a lot, my colleagues. And I think, again, in the last few minutes, I want to thank the Perry World House for allowing us to do this communication. This is the best thing we can do. And I see there were well over 100 participants. And if we did our job right, then we did communicate correctly. We haven't had a chance to answer all the questions. I think we got to many of them. And I certainly will be available to answer any questions, and I can find Rick and Susan if I have to, and I can get you the answer. So Michael, I'll turn it back to you and your team. Please let your folks know that we are around to answer questions. That's what we have to do. And I'll turn it back to you.
Well, be careful what you wish for. But the Perry World House audience is an active bunch. But thanks to all of you for joining us today for this incredible and educational event. I mean, I think that we're all focused on, I think many people are focused on, all right, when can I get vaccinated? But there are lots and lots of other questions in some ways that we still need to answer, both in thinking about the resolution of this pandemic and in thinking about the next pandemic. And we're really grateful for and appreciate the three of you taking the time to join us today. And thanks again to the Penn Center for Research on Coronavirus and Other Emerging Pathogens for partnering with us on this important event. And thanks to our audience for joining us for this edition of The World Today. And we hope to see you next week on a special date of Friday, March 26th at 12 p.m. Eastern Time for the keynote conversation of our 2021 Global Shifts Colloquium, Locked Down, as we've all felt for a long time, Global Mobility and COVID-19, with our special guest, the UN Refugee Agency's High Commissioner, Filippo Grandi. He leads the UNHCR, which operates in 135 countries, providing protection and assistance to more than 80 million refugees, returnees, and internally displaced in stateless people. He's going to talk about how COVID-19 has impacted forcibly displaced people around the world. And we also hope you'll sign up for our World Today on April 13th, A Better Dead Than Red, to discuss the enduring legacy of the Red Scare with Perry Worldhouse visiting fellow Clay Risen of the New York Times. As always, you can access a recording of this conversation on our YouTube channel. You can find out about all the great events we have planned for next semester by joining our mailing list, following us on Twitter, Facebook, and Instagram at Perry Worldhouse. We'll drop links to everything in the chat as well. Thank you all for being with us today. Again, this was so educational on what is undoubtedly, the defining moment, defining period of many of our lives. And you've all played a critical role in what our response at a local level, at a national level, at an international level has been to this pandemic, and we're deeply grateful to all of you. So thanks everybody for joining us today, and have a great day.
Thank you.
Thank you. Bye.